We're going to start off right away. If we're already not meeting the Schaefer standard here on starting on time. So, good afternoon. I'm Lee Goldberg. I'm with the Pew Charitable Trusts. We've got a project on improving end-of-life care that, for the last 2 years, has been working on a lot of the issues that have been brought up by this roundtable and by the Dying in America report from the IOM, including the issues today around innovative models of care. We're actually working on a project with CTAC on a report that's going to be out hopefully in September, highlighting a number of models of care and policy barriers they face. So if you're interested in this issue, if you're here today, look for that report. So we heard earlier in the day from a number of pioneers who are leading innovative programs, and they have incorporated policies of principles of community-based palliative care. This panel right now is a time to reflect on that and think about how to move from what's happening out in the field to moving policy, translating some of the aspirational goals that motivated those plans and that are getting results in the field. Translating that to concrete policy is often very difficult, but we've got a couple of experts to help us here and a lot of expertise in the room to have a discussion about it afterwards. So joining us for this discussion are two thought leaders in healthcare who between them have a wealth of experience on both sides of the aisle and on both sides of Pennsylvania Avenue. Bill Hoagland is the Senior Vice President for the Bipartisan Policy Center and a former executive at Cigna and a longtime staffer from various Republican senators. Bill will discuss the recent recommendations from the Bipartisan Policy Center's report on high-cost, high-need Medicare patients. After Bill's presentation, Dr. Jain, who is from CareMore, will join us in the discussion about policy opportunities for scaling up some of the innovative work we've heard about. That's, I think we're all well aware that that's the next challenge, either scaling up those models or incorporating the lessons of those models into the public health care programs. Dr. Jain was previously, as he mentioned, an executive at Merck, and before that was with the Obama administration, where he was a senior advisor to the administrator of the Center for Medicare and Medicaid Services, Don Berwick, and a special assistant to the Office of National Coordinator for Health IT. So Bill and Sasha and I will take a few minutes to go over a few questions, but then I want to open it up for the audience and we'll have a robust discussion. Bill.
Good afternoon, everyone. They always put the budget guy on at the last panel, so thank you for the opportunity to speak to you this afternoon, and particularly I've been able to listen to a number of your panels here this afternoon, and so I want to give a shout out to all of you providers. I think what you're doing is important and very beneficial, and certainly really great work that you're doing out there. The focus of this session and this panel, as the title implies, is the policy directions, and so I'm going to talk a little bit about the pathways that maybe policymakers might take this issue to meet that triple aim of a goal of improving the care and improving health of the populations and also reducing the cost of health care. I'm going to highlight a little bit about what, as Lee has said, what the Bipartisan Policy Center has been doing here on a subset of Medicare patients with serious illnesses. And let me begin, though, by saying, well, I think there are very, very many challenges, and I've heard a lot about them this afternoon, on integrating palliative care into serious illness care. Let me start with what I deal with a lot of Hill staff, mostly on the Senate side, where I spent close to 30-some years up there and with members. But let me just relate to you on a positive note. I believe policymakers get it. I think they have reached a consensus that improving the quality and availability of medical and social services for patients and their families will not only enhance quality of life through the end of life, but they also contribute to a more sustainable healthcare system. The eminent Professor Robert Gorton at Northwestern University, in one of his recent books, and let me quote what he said, even many seniors who do not face the problems of serious chronic conditions such as Alzheimer's or Parkinson's disease will spend their additional years in and out of hospitals where they will receive high-tech, high-cost interventions while they suffer from a lack of low-tech, high-touch services. I think that's what I've learned here this afternoon is really important. So first of all, who are we, the Bipartisan Policy Center? We are established, if you can believe bipartisanship in this town, and bipartisanship, it was established 10 years ago by 4 former majority leaders of the United States Senate, Senator George Mitchell and Senator Tom Daschle on the Democratic side, and Senator Bob Dole and the late, and I consider great, Senator Howard Baker from Tennessee on the Republican side. They obviously have come together with trying to find ways of taking on some of these major critical issues and finding bipartisan solutions to them. We established a working group on long-term care initiatives made up of both Senator Daschle and Senator Frist, my last boss on the Hill, Secretary Tommy Thompson, and my first boss on Capitol Hill way back when the Congressional Budget Office was established, Alice Rivlin. So let me begin by wearing my budget hat first. Policymakers tend to look at the aggregate kind of expenditures. But I was appreciative that Senator Frist and Senator Daschle, who are on the NAM's recent steering committee on vital directions, in their JAMA article last month on the priorities of the committee, highlights with this slide the fact that high-need patients disproportionately drive health care costs. I think you're all familiar with the statistics of the total personal health care spending in 2014. Only 1% of the population accounted for 23% of all spending, and the top 5% accounted for well over half of all spending. Looked at in a different way is the way the policymakers tend to look at it, and they look at the aggregate level of spending and the rate of growth. And what they're looking at is the rate of growth in Medicare or Medicaid is outstripping the rate of growth in the economy. And as a consequence, they conclude that this cannot be sustainable over the long term. But if we break it down even more, finally, we know that of all the Medicare fee-for-service beneficiaries, we're looking now just at the Medicare fee-for-service beneficiary, a third, 36%, of the beneficiaries with 4 or more chronic conditions accounted for 3/4 of all Medicare fee-for-service spending. And looked at even slightly differently here, without taking into consideration the number of chronic conditions a beneficiary that beneficiary may or may not have, the concentration of spending is even more glaring. Only 10% of Medicare beneficiaries in 2012 accounted for nearly 60% of all program spending in that year. And further, even add to it, as some statistics I heard earlier today also, that the average Medicare per capita spending was $14,000 in 2016. If that beneficiary had even 3 or more chronic conditions and had functional disorders and impairments, the average expenditure was more than double that if they had more than 3 at $30,000. And I think it should be clear simply that if policymakers are concerned about cost, which they tend to be, they must focus their attention on those who contribute the most to those costs. It's the old Willie Sutton rule. So, with all this as background, what were we doing at BPC and what was our focus? We focused on 2 distinct high-need, high-cost populations, the dual-eligible individual and the Medicare-only beneficiary. And when we looked at these 2, we concluded in general that while both populations had common features in terms of health status, behavioral health needs, and assistance required in activities of daily living, the policy challenges were definitely different. For the dual-eligible populations, the working group and the BPC concluded that the issue was integration of Medicare and Medicaid benefits. But for the Medicare-only population, the issue was lack of flexibility and financial incentives to provide non-Medicare covered social services. Over the course of the last year, we have issued 4 reports. I'm going to focus on the last 2, and the most recent one, which was just released on Tuesday, which Dr. Jane here was involved in with our release. First, of the nearly 10.3 million estimated dual-eligible beneficiaries in 2015, only 20%, 2 million, were enrolled in systems of organized care, such as DSTIPs, Medicare, Medicaid plans, or the PACE program that we heard about in the previous panel. This highlights, I think, to me, from a policy perspective, the first major difficulty of providing integrated care for this population when there's such a limited number of duals are enrolled in coordinated care settings. Traditional Medicare fee-for-service remains the predominant form of coverage out there. Medicare dual eligibles, as well as and nearly 60% of Medicaid dual eligible beneficiaries receive their Medicaid benefits through the fee-for-service arrangements. So the recommendations we put forward as it relates to the dual eligible population essentially fell into 4 areas. First and foremost, straightforward, the current Medicare Advantage Special Needs Plans, DSNPs, should be permanently reauthorized. Their authorization expires next year. We've put forth that recommendation. But we also say that in addition to reauthorizing, we would set a requirement that by the year 2020, the plan should become fully integrated with clinical health care, behavioral, and LTSS services. Second, for the ongoing financial alignment demonstrations out there, the contract should be modified to permit the unanticipated infrastructure investment associated with starting up these special needs programs, and that rather than having the deficit, that they be deficit neutral every year, that be stretched out to be deficit neutral over 5 years. Third, administratively, the regulatory authority for reimbursement into a single office within CMS needs to be unbelievable. Existing agencies within CMS having jurisdiction over SNPs, PACE, demonstration projects, and other services, they're spread throughout, they're not integrated. We talk about integration, we're not even integrated here in the CMS operation. And finally, we recommend that there be a new revised regulatory structure be established to serve this particular population. Finally, I guess the overall conclusion here for the duals is rather simple. If we are to be successful in integrating palliative care into services for the seriously ill and vice versa, we need to increase the availability of coordinated care in the system out there, or it will never work. As it relates to the other high-need, high-cost Medicare-only population, we first identified what we saw as some of the barriers to providing care to this population, whether they be through MA plans, ACOs, or patient centers. And there are 5 areas that we identified right off the bat. Was a uniform benefit problem, a health-related benefits provided in supplemental benefits had to be primarily, quote, primarily health-related, program integrity rules, the medical loss ratio rules, and the lack of financing associated with the risk adjustments. So no surprise, I guess, our recommendation issued this last Tuesday followed the barriers, and we are, quite frankly, I think many other people, as you have identified here even today, those same barriers. But most importantly, the major recommendation, not all of them, but the major ones follow. First of all, reform the MA uniform benefit to allow for targeting of supplemental benefits on a per-person basis, not a uniform one-shoe-fits-all. Allow the MA plans to offer supplemental benefits that are not primarily health-related, so long as they are person-centered for the chronically ill person. In the calculation of the MLR ratio, which I believe is required at 85% factor, allow for the cost of the non-covered, non-supplemental benefits to meet the MLR requirements. And importantly, the risk adjustment model should be itself adjusted. The current CMS HCC risk adjustment model has been estimated to underpredict the medical cost of this population by nearly 30%, while predicting the lowest cost beneficiaries by nearly 60%. As the result, there are less resources for the care and a disincentive, quite frankly, to attract the frail eligibles who are likely to be those high-cost individuals. From a cost perspective, only as an illustrative analysis, we analyzed 4 potential supplemental benefits: in-home meal deliveries, a non-emergent medical transportation, minor home modifications, and a targeted case management. What we found was interesting, and I tend to be a little tight on the budget, but we found that the average monthly cost of providing these benefits range from $50 per recipient for transportation to $360 per recipient for a daily home delivery of fresh meals. Now, ranges across the country, we understand. But what we also found was that if this cost for the eligible population I'm talking about here, 3 or more chronic care conditions, if it were spread across the enrolled Medicare Advantage plans, the PP per beneficiary per month cost would be about $5. Since the average PPM rebate for MA plans in 2017 will be almost $90, we concluded that providing these additional benefits could be financed within the existing MA payment system and structure without adding to the cost. Now, in fairness, we did not, and it's difficult to do with the data. I wish I was over at the Data Palooza this morning to hear about all this, but determine the potential. We cannot quite determine the potential overall savings to Medicare writ large from reducing avoidable high-cost medical events such as hospitalization from providing these, quote, soft touch. But I do think the point being made is it can be done, and it can be done within the existing structure. So how we fared? Are the policymakers responding? Well, of the 10 major recommendations from our 2 reports on the duals and Medicare-only population, I can report that the words, in his own words, the chairman of the Senate Finance Committee, Senator Hatch, the first major bipartisan health bill introduced in this new Congress, the 115th Congress, was a committee-wide effort to improve the outlook for patients with chronic conditions. The bipartisan bill introduced earlier this month also it was entitled Creating High-Quality Results and Outcomes Necessary to Improve Chronic Care Act. The acronym is CHRONIC, and it embodies at least 5 of those 6 recommendations. Most rewarding, however, for me in the legislation is the provision to allow MA plans to target supplemental benefits and to waive the restriction that MA benefits be primarily health-related services. Further, I should close by simply saying, and other major there was one less piece of major bipartisan legislation that was enacted in the last session of Congress in December in the lame duck, the 21st Century Cures Act signed into law in the final hours. It addressed that risk adjustment factor and made some access to MA programs for Medicare-eligible individuals with end-stage renal dialysis. So let me conclude that despite the fireworks over the future of the ACA in Congress, progress is being made, if so slightly toward focusing, I think, on improving the quality and availability of medical and social services for patients and their families to enhance the quality of life for patients with serious illness that I argue will benefit not only them through the end of their life, but also benefit the public purse. Thank you very much.